Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I'm a cardiologist from Houston, Texas. Today we are going to be talking about EKG interpretation, bradycardia. This is based on my book, Clinical EKG Interpretation and Patient Management. And you can take a look at this book on Amazon.com. And also, please look at the videos on introduction and electrical axis. We also have a video on conduction disturbances and bundle branch blocks. There is a separate video on chamber enlargements. In this presentation, we're going to be looking at the sinus node dysfunction and bradycardia. Please do subscribe to our YouTube channel and let us begin. In chapter 6, we're going to be talking about sinus node dysfunction, which will include sinus pauses, sinus exit block, sinoatrial block, sinus arrhythmia, and sick sinus syndrome. As you can see in this diagram, the sinus node is located at the junction of the superior vena cava and the right atrium. Most of the things we're going to be talking today will be related to the dysfunction of the sinus node. What is your diagnosis? Take a moment and write down your diagnosis, and more importantly, write down all the findings you see in this electrocardiogram, and when you're ready, let us continue. What we see here is a sinus rhythm with a sinus beat, another sinus beat, and there's a long pause followed by a sinus beat, and another sinus beat. So this is an example of a long sinus pause. The ACC/AHA guidelines suggest that sinus node dysfunction is due to age-dependent progressive fibrosis of the sinus node tissue and the surrounding atrial myocardium. It can lead to abnormalities of sinus node and atrial impulse formation and propagation. It can result in various bradycardic or pause-related symptoms. This type of a sinus pause could be found in a variety of conditions such as sick sinus syndrome. It can also be seen in patients with sleep apnea. Sleep apnea is often associated with the sinus pauses and bradycardia. The treatment of sleep apnea actually reduces the frequency of these type of arrhythmias and also improve overall cardiovascular function. Hence, it is very important to make sure that we do sleep studies to determine not only the oxygen saturation, but also the heart rate, heart rhythm, and any evidence of heart blocks. Patients with sleep apnea can also have various degrees of AV block during a sleep study. Some of the features of long sinus pause include: here the PP intervals in the conducted beats are normal. The RR intervals, however, are irregular. The P waves may be present or the P waves may be absent. And in sinus pause, the pause is not usually a multiple of the PP interval. The PQRS ratio is 1:1 when it is conducted. The PR interval is usually normal, unlike in patients with Wenckebach, and the QRS generally is normal unless there is an underlying bundle branch block. All right, let's move on to the next type of sinus arrhythmia, and that is the sinoatrial exit block. At the beginning, I told you about the location of the sinus node. Sinus node spontaneously depolarizes, producing an electrical action potential. That action potential activates the right atrial system through the atrial connections, and thus it activates the contraction of the atria. However, in certain conditions, the activation of the sinus node impulse may not come out of the sinus node. As a result, the atria fail to receive any signal from the sinus node, and that results in what is called sinus exit block. This is what we are seeing here. Here we have an atrial activation followed by a QRS activation. Here's the same thing, and here we have the same thing. Now when the next atrial impulse is supposed to come somewhere around here, we don't see the sinus impulse or the atrial activation. There is resumption of the sinus rhythm. Look at, we already have a sinus arrhythmia, we have sinus bradycardia along with sinus exit block. Usually the sinus exit block does not cause compensatory pause, so the sinus exit block measures 2 times the PP interval. So these are some of the features of a sinus exit block, which is type 2. Here's another point from the ACC/AHA guidelines. In sinus node dysfunction, there is no established minimum heart rate or pause duration where permanent pacing is recommended. Establishing temporal correlation between symptoms and bradycardia is important when determining whether permanent pacing is needed. So the determining factors are going to be the patient symptomatology and the symptoms being directly related to the sick sinus syndrome or bradycardia. What do we see here? Again, we have a sinus bradycardia here. We have a sinus rhythm. However, there is a little pause here. Whenever you see a pause, the first thing you want to do is look at the T wave and the segment immediately following the T wave for any type of deformity that may suggest a premature atrial beat that may be blocked. Here the T wave morphology is similar in these 3 beats, and here it looks a little different. So whenever you see this, you always wonder, is this representing a premature atrial beat which is blocked with a compensatory pause following that normal looking cardiac cycle? So whenever we see pauses, we should always think about ectopic beats creating the pause and thus resulting in bradycardia. Okay, here are some more features relating to sinoatrial exit block, which is type 2. That is, the PP cycles are constant. As I told you before, the PP cycles are constant. Where there is a sinus exit block, we don't see P waves or QRS complexes. And generally, the pause is 2 times the preceding PP interval. Here's another example of sinus exit block where we have a PP interval which is 0.86 seconds, and this is 2 times that, and then we have resumption of the regular sinus rhythm. This is another example of sinus exit block. Alright, what do we see here? It looks similar to the previous electrocardiogram we saw. We have a sinus beat and a sinus beat, and there is no atrial or ventricular activity. Then we have resumption of the sinus beats followed by another similar pause. So whenever we see these kind of grouped beats, we need to think about Venki block or second degree heart block. However, we don't see any atrial activity whatsoever, then you should think about sinus exit block. And here's an example of sinus arrhythmia. As you can see, the RR intervals vary from beat to beat, and it slows down, then it gradually picks up and again slows down. We can see variable RR intervals in a variety of conditions such as atrial fibrillation with variable ventricular response, multifocal atrial tachycardia, or even flutter with variable ventricular response. But here we see definitely P waves preceding each QRS complex, and that's what makes it interesting because we are dealing with sinus arrhythmia. Here's an example of what could be a short run of atrial fibrillation followed by a long pause and some junctional beats, and again resumption of some sinus beats followed by another bout of supraventricular tachycardia. So this is an example of a sick sinus syndrome with the tachyarrhythmia and bradyarrhythmia seen in the same strip. We see this frequently in patients with underlying atrial fibrillation, where there is coexisting sinus node dysfunction resulting in pauses that gives rise to sick sinus syndrome. Sick sinus syndrome is a significant challenge when it comes to managing rate and rhythm. If we treat the fast rate, it can make the slow rates worse, and if we don't address the slow rates, we'll have a tough time controlling the fast rates. So in these patients, invariably a pacemaker will be one of the most important options to control the slow rate with the pacemaker, and then use drugs to control the rapid ventricular response from the tachycardia. All right, that concludes our brief review of sinus node dysfunction. Let's continue on to chapter 7, where we can look at bradycardia. We're going to look at sinus bradycardia, slow junctional rhythm, ventricular rhythm, idioventricular rhythm, agonal rhythm, asystole, and sometimes lead misplacement, and also certain arrhythmias masquerading as bradycardia. So let us continue. Bradycardia not only can involve the disease of the sinus node, more often it involves the disease of the AV node, which can slow down the conduction and sometimes totally block the conduction, under which circumstances we may end up seeing junctional rhythm, idioventricular rhythm, or even agonal rhythm. So let us look at some of the examples and see how we manage patients with bradycardia. Most of the time, bradycardia is related to disease involving conduction system at various levels. It could be, as I told you before, at the sinus level, it could be at the atrial connections, it could be at the AV node. A lot of times they are related to inflammation, genetic mutations, and very often they are related to drugs. Whenever you see bradycardia, you always have to look at the patient's medications, reconcile their medications, and see if the medications are the main cause for bradycardia. Here are the electrolytes that are used in the action potential, which we covered in earlier chapters. Here is an example of sinus bradycardia, where the heart rate is considerably slow, but we have regular PP cycles, regular RR cycles, regular PR interval. So this is a classic example of a sinus bradycardia. So the rate is less than 50 beats per minute. How do we define symptomatic bradycardia? Symptomatic bradycardia is associated with a heart rate that is slow. The patient has symptoms, and these symptoms are related to the bradycardia. When we have all these three features, then we are talking about symptomatic bradycardia. Causes of pathological sinus bradycardia could include sick sinus syndrome or sinus node dysfunction, infarction or cardiac surgery, infiltrative processes such as amyloidosis, sarcoidosis, increased vagal tone, most importantly medications, and some genetic disorders. Let's look at some of the intrinsic heart rates. The sinus node has an intrinsic heart rate of 60 to 100 per minute. Similarly, the atrial rate can vary from 60 to 100 beats per minute, but the moment we get disease involving the AV node, if we see a junction, if we come across a junctional or a His bundle rhythm, the rate could be anywhere from 40 to 60 beats per minute, and generally we are going to have a narrow QRS complex, and if the impulses are arising from the ventricles, then we're going to have a heart rate of 30 to 40 beats per minute, and of course you're going to see wide QRS complexes. It could be idioventricular rhythm, it could be even accelerated idioventricular rhythm or agonal ventricular rhythm. We're going to look at different examples and finally conclude with how we manage symptomatic bradycardia. Let us continue. Okay, here is an example of a very slow. Here's an example of a very slow heart rate. I want you to take a moment and write down all the findings you see in this rhythm, in this electrocardiogram, then we can continue. So we have a bradycardia. If you look at the beats, we have the constant PR interval. The ventricular rates are also constant. The heart rate is 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's almost like a little more than 30 beats per minute. Whenever you see bradycardia with a narrow QRS complex, always, as I said, look at the T waves and see if there are hidden ectopic beats creating a rhythm which looks like bradycardia, but it could be a bigeminal rhythm with a long pause. If it's a ventricular ectopic beat, obviously you're going to see the wide QRS complex and you can easily identify. But however, if it's a blocked atrial beat, then you will have a hard time trying to determine whether that is actually a blocked atrial beat or whether this is just garden variety severe bradycardia. If you pay particular attention to the T waves, they kind of look funny. As you can see, and here you can see a little notch here, and then we see the P wave. So whenever we see something like this, we should always keep in the back of our mind, are we dealing with a sinus rhythm with blocked PACs creating atrial bigeminy, which is resembling like severe bradycardia. Sometimes it may not be easy to determine that this is atrial bigeminy. What are the differential diagnoses? Whenever we see slow rates, we look at these notches in the T waves, then we think about atrial premature beats. The second thing we want to think about is this 2-to-1 AV conduction, that is second degree heart block type 2. For it to be second degree heart block type 2, the PP interval should be constant. But here, from this P to this P and from this P to this P, the intervals are not constant. That's what makes this particular deflection a premature atrial contraction. So if this is premature atrial contraction, then we are dealing with a sinus rhythm with blocked atrial premature contractions with a compensatory pause resulting in what appears to be, what is a bradycardia. So that's how I want you to more importantly analyze the electrocardiograms than jumping to conclusions by just looking at first glance. And here are some more tips from the ACC/AHA guidelines. In a patient with bradycardia, who have indications for pacemaker implantation, a shared decision-making and patient-centered care are endorsed and emphasized in this guideline. That means if we have a symptomatic bradycardia patient, a shared decision making should be taken into account. The treatment decisions should be based on the best available evidence and on the patient's goal of care preference. We may be dealing with bradycardia, but if the symptoms are far and few, and if the patient is sedentary, then the patient may not be interested in having a pacemaker, or if the patient is nursing home bound and the family is not interested in having a pacemaker and prolonging the life. Hence, involving the family and the patient are very important points when deciding whether the patient would benefit from a pacemaker or not. Supraventricular beat here. Here's a supraventricular beat with a different morphology, and here's another supraventricular beat. Take a moment, look at this strip, write down all the points, then we will continue. First of all, at the first glance, it is supraventricular rhythm. Number two, the heart rate is slow. So we have a bradycardia. And now let's look at the P waves. We have a regular P wave here, regular P, regular P, regular P. So we have regular P and constant PR intervals. We have constant PR intervals. Then we have narrow QRS complex with a little terminal slurring. This could be a patient with a right bundle branch block, but let's focus more on the rhythm. Okay, what else do we see? As I told you in the previous two electrocardiograms, whenever you see bradycardia, always look for hidden clues. And here is a hidden clue. There's a notch in the T wave. There's a notch on top of the T wave here, 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 and we don't see that well here, but here we got a normal beat here. So the moment we see these notch, the moment we see distortion of the T wave, then we need to see if we are looking at multiples of P waves between the QRS complexes. Okay, if this is a P wave, if this is a P wave, if this is a P wave, this is a P wave, then we are talking about second degree AV block with then we are talking about second degree AV block type 2. Why do I say type 2? Well, it could be type 1 where we just have one beat one beat Venki-Bach. It would be kind of hard to differentiate that from type 2 where we have constant PP intervals. Anyway, so this is an example of second degree AV block type 2 with blocked P waves resulting in bradycardia. So let us continue. Here we have a different rhythm here altogether. This rhythm is reflective of junctional rhythm. This is an escape junctional rhythm. We don't see any definite P waves. So this is an escape junctional rhythm. Whenever we see escape junctional rhythm, we should always consider the possibility of drug-related junctional rhythm. There are a number of drugs, including beta blockers, calcium channel blockers, and digoxin, which can cause junctional rhythm in the presence of sinus rhythm or even in the presence of atrial fibrillation. We're going to look at another example of that. It could also be a idioventricular rhythm, in which case the QRS complex will be wider. So if the QRS complex is greater than 120 milliseconds, that is occupying 3 squares, then it would be considered idioventricular rhythm. So here it is almost just a little less than 120 milliseconds, but this could also be a idioventricular rhythm. Let's move on. In a junctional rhythm, the heart rate is between 40 to 60 beats per minute. We may or may not see the P waves, and if we do see the P waves, usually the P waves may occur after the QRS complexes, or if they are appearing before the QRS complexes, the PR interval will be really short. The RR intervals are regular. The P waves, as I said, could be variable. The PQRS ratio is 1:1 if the P waves are visible. The PR interval, as I told you, could be very short or it could be retrograde. And the QRS width is normal, and that's what differentiates this from idioventricular rhythm or accelerated idioventricular rhythm. I was talking about junctional rhythm just a few minutes ago, and whenever we see an atrial rhythm which looks like atrial fibrillation, and you see a fairly regular narrow QRS rhythm, you should always think about atrial fibrillation with escape junctional rhythm. And when you see this, you should always consider the possibility of significant AB nodal disease, which may be compounded by drugs, which I already talked about, beta blockers, calcium channel blockers, or digoxin. If the patient is on digoxin, you can almost think that this is related to digitalis toxicity. So we are dealing with atrial fibrillation with junctional escape rhythm. That means we not only have a disease involving the sinus node, we also have a disease involving the atria, along with the disease involving the AV node and perhaps maybe conduction system also. So when we see patients like this, the treatment options become pretty obvious. Talking about treatment, when we are dealing with symptomatic sinus bradycardia or atrioventricular block, here are some of the main drugs that we can consider. Atropine, 0.5 to 1 milligram IV, may be repeated every 3 to 5 minutes to a maximum dose of 3 milligrams. Or dopamine, from 5 to 20 micrograms per kg per minute IV. We start at 5 micrograms and gradually increase by 5 micrograms every 2 to 5 minutes. Isoproterenol, ranging from 20 to 60 micrograms IV bolus, followed by a dose of 10 to micrograms or an infusion of 1 to 10 micrograms per minute based on the heart rate response. And of course, we can also use epinephrine infusion at 2 to 10 micrograms per minute. If the bradycardia is related to calcium channel blocker, overdose, we can use a 10% calcium gluconate, 1 to 2 grams over 10 to 20 minute duration, and it can also be followed with an infusion of 0.2 to 0.4 ml per kg per hour calcium chloride, and similarly we can use 10% calcium gluconate. If we are dealing with an excess dose of beta blockers, then we can use glucagon, 3 to 10 milligram IV with infusion of 3 to 5 milligrams per hour, and they can also be treated with a high dose insulin. And if this is related to digoxin toxicity, of course, using digoxin antibody fragment can help to reduce the serum digoxin level and thus improve the bradyarrhythmia. So this is an important table to keep in mind, because you can get several questions related to treatment of bradycardia, especially the dose and the drugs. Okay, can you take a guess? This is just a trick. We already saw this electrocardiogram. We talked about this little notched T wave, which may be perhaps atrial bigeminy causing bradycardia. Let's move on to the next one. All right, take a look at this electrocardiogram very carefully. Write down all the findings that you see, and then we can proceed. At first glance, it looks like bradycardia. And of course, it is bradycardia because the RR intervals are like less than 30 beats per minute. And we also see P waves, but there are multiple P waves. We see a P wave here, we see a P wave here, there's 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 a P wave, P. So we see P waves, but do we see a correlation between the P waves and the QRS complexes? So that's the next question. Are the PR intervals constant, or do they vary in a certain set pattern? No, there is no relationship between the P waves and the QRS complexes. So we have AV dissociation. Along with that, we have right axis deviation here with the negative deflection in lead 1 and a positive deflection in AVF. So this is like isoelectric, this is isophasic in AVR. So we are looking at a right axis deviation of a plus. So we are looking at a right axis deviation of a plus 120 degrees. Along with that, we have what looks like right bundle branch block or right ventricular hypertrophy with discordant STT changes. There's a whole lot of changes going on in this electrocardiogram. We have a complete heart block with right axis deviation, and we have right ventricular hypertrophy along with the discordant STT changes. How do you deal with this patient? What is the treatment option? Before we go into the treatment option for that complete heart block, let's look at some examples of idioventricular rhythm. As I said, the idioventricular rhythm is an escape rhythm. When the junction doesn't kick in, the ventricle starts its own rhythm. So we have an idioventricular rhythm with no P waves, wide QRS complexes, and discordant STT changes. Here's another example of idioventricular rhythm where along with some sinus beats in between, along with sinus notes, sinus beats in between. As I explained, this is a wide QRS complex with discordant STT changes. Okay, if we are dealing with third degree atrioventricular block, which is associated with acute myocardial infarction, then we can try aminophylline 250 milligram IV bolus, or it can be given as 6 milligrams per kg in 100 to 200 ml of IV fluids over 20 to 30 minutes. This can be used in patients with acute myocardial infarction, post-heart transplant, or patients with spinal cord injury who can be treated with theophylline 300 milligrams IV followed by oral dose of 5 to 10 milligram per kg per titrated per day, titrated to effect. But the most important treatment for atrioventricular block is going to be pacemaker. So this is just a temporary gap until we can get these patients a permanent pacemaker or a temporary pacemaker. Second degree Mobitz type 2 atrioventricular block, high grade atrioventricular block, or third degree atrioventricular block that is not caused by reversible or physiological causes like drugs, etc. These patients need permanent pacemaker regardless of whether they have symptoms or not. If we are dealing with a symptomatic bradycardia patient who is hemodynamically unstable, and if this patient has significant bradycardia, if a transcutaneous pacemaker is available, then we should consider transcutaneous pacemaker after having tried the drugs we talked about for symptomatic bradycardia. Otherwise, if a permanent pacemaker capability is available, we can insert a permanent pacemaker. If a permanent pacemaker is not available, we can temporarily pace these patients using either external pacemaker or temporary transvenous pacemaker. That concludes our presentation on chapters sinus node dysfunction and bradycardias. In the next video, we're going to be covering supraventricular arrhythmias. This is an important chapter, so stay tuned and please do subscribe to our YouTube channel, and we'll see you next time.